This week, the direct oral anticoagulants are discussed in this Medicine of the Week. Direct oral anticoagulants are also called DOACs. Well-known examples are dabigatran and apixaban. DOACs directly inhibit fibrin formation. There are two routes through which this inhibition takes place. Apixaban, edoxaban, and rivaroxaban inhibit fibrin formation through inhibition of coagulation factor 10A, whereas dabigatran inhibits thrombin. The effect of both routes is a decrease in the amount of clots. The difference in the mechanism of action is clearly visible in the name. You have inhibition of thrombin by dabigatran and the inhibition of factor 10A, also written as XA, by apixaban, edoxaban, and rivaroxaban. DOACs can be given for different indications. The most important ones are prevention of venous thrombosis after elective hip or knee replacement surgery, or a therapeutic treatment of acute deep vein thrombosis of an arm, leg, or lungs, also known as pulmonary embolism. DOACs are given to prevent thromboembolic complications of non-valvular atrial fibrillation, such as stroke, in high-risk patients. The CHOTS-FOS score is a clinical prediction scoring method to estimate the risk of stroke in people with non-rheumatic atrial fibrillation. If someone scores 2 or more points, generally anticoagulation is recommended. The dosage and time of administration differ per indication and per DOAC, so there are several dosing schemes possible. Sometimes the doses have to be adjusted based on the patient. We will discuss this later on. Routine screening of the anticoagulant effect with INR measurements is not needed for DOACs. This is due to their predictable pharmacokinetic profile and relatively limited interactions with both food and drugs. This makes the DOACs more user-friendly for the patients compared to, for example, vitamin K antagonists, while still being equally effective in preventing thromboembolic events. As said, DOACs are used for different indications. However, they are not suitable for use in patients with antiphospholipid syndrome or as prophylaxis for thrombosis and stroke in patients with a mechanical heart valve. Caution is also advised when using DOACs in patients with a high risk of bleeding, for example in the stomach. This risk can also be increased by concomitant use with other drugs with bleeding as side effects. Examples are acetyl salicylic acid or NSAIDs. The main side effect of a DOAC is, of course, bleeding. Therefore, there are a number of precautions to reduce that chance. In some indications, there are factors that additionally increase the risk of bleeding. For apixaban, these factors are an age greater than 80 years, body weight less than 60 kilograms, and a serum creatinine greater than 133 micromoles per liter. If a patient meets 2 of these 3 characteristics, the dose should be halved for the indication of stroke prevention or systemic embolism due to atrial fibrillation. This is similar for edoxaban, with a body weight less than 60 kilograms or a creatinine clearance less than 50 milliliters per minute, or both, the dose should be halved. For dabigatran as well, the dose must be reduced in the case of advanced age or impaired renal function. In case of severe decreased renal function, dabigatran should even be avoided. This is, as with apixaban and edoxaban, due to the accumulation of drug in the blood. Nurses are an integral part of the team, both in the hospital and in home care. They are required to monitor for signs and symptoms, change, or to stop anticoagulation. Symptoms could be chest pain or changes in shortness of breath. Report these signs to the doctor as soon as possible, as these could be signs of a pulmonary embolism, for which anticoagulation might be needed. Also, if the patient has asymmetrically swollen legs or has tender calves, these could be signs of a deep venous thrombosis, a blood clot in the calves. Patients who are bedridden are at a higher risk of developing blood clots. This could be due to their underlying diseases or the lack of movement. If the patient is mobile, make sure to stimulate the patient to move around as much as possible. Make sure it is safe for the patient to do so and has a limited risk of falling. If the patient is unable to move around by themselves, try sitting them up in a table or at their bed. Just sitting up already is more beneficial than lying down, as lying in bed weakens the muscles and increases the risk of developing blood clots unnecessarily. Once the patient is on DOACs or any other type of anticoagulation, be aware of symptoms of side effects. It is important to regularly check for any signs of bleeding. These include checking the stool or asking the patient to check. Inform the patient how to recognize melena. These are black, tar-like, sticky stools with an unusually offensive smell. Monitor blood pressure, as a sharp drop in blood pressure could indicate uncontrolled bleeding. Also check for signs of extensive bruising. Regularly assess a patient's risk of falling and try to minimize this risk. If the patient unfortunately has fallen nevertheless, especially on the head, always inform your physician. Patient education is important. Anyone involved in the medication process plays their part in this. Inform the patient of the risk of anticoagulation and how to recognize the previously mentioned signs of bleeding. The patient should be aware of alerting a physician or a nurse in case of heavy bleeding or a fall in the head. There are signs that the patient is non-compliant with taking a DOAC, either in a hospital or at home. Explore why this is the case in a non-judgmental manner. This could happen when patients don't pick up their medication in a pharmacy on time, for example, or during medication rounds by nurses or visiting hours of the physician. If your suspicion is confirmed, find out the reason for the non-compliant behavior and try to help the patient in finding a way to compliant behavior. For instance, by discussing the reasons and the importance of taking DOACs. Always properly document your findings so the rest of the team stays in the loop. Fortunately, antidotes are also available for DOACs, should serious bleeding occur nevertheless. The specific antidote, andoxanet alfa, is available for use against apixaban and rivaroxaban. The antidote idarucizumab exists for dabigatran. An antidote can be administered in emergency operations, urgent procedures, or life-threatening uncontrolled bleeding. Although specific antidotes for DOACs are available, prothrombin complex, also known as Cofact, is usually given in practice. As the name suggests, it increases the thrombin concentration so that clotting starts again. In practice, Cofact is cheaper and easier to use than the previously mentioned antidotes. DOACs can interact with other medication. This is usually via CYP enzymes or P-glycoprotein. The DOACs are substrates of different combinations of CYP and P-glycoprotein enzymes. You can see these specific enzymes in the table. Inducers of these enzymes cause the concentration of DOACs in the blood to decrease. Examples are rifampicin, phenytoin, carbamazepine, and phenobarbital. Whereas inhibitors of these enzymes cause the concentration to increase. These are medications like antifungals or HIV protease inhibitors, such as ritonavir. In some cases, when a specific inducer or inhibitor cannot be replaced or stopped, the choice of a vitamin K antagonist might be safer. To summarize, DOACs are reversible and direct inhibitors of coagulation factor 10A or thrombin. DOACs are used for the prevention of thrombosis, thromboembolic complications, as well as the therapeutic treatment of thrombosis or pulmonary embolism that had already developed. Specific antidotes are available for DOACs. Andoxanet alfa for apixaban and rivaroxaban, and idarucizumab for dabigatran. In practice, prothrombin complex is often given as an antidote for DOACs. DOACs are also substrates for some CYP enzymes and P-glycoprotein, so watch out for drug interactions.